So this video is a continuation of previous video which I made on A-scan. So today we are discussing on B-scan. So B-scan is known as brightness scan. So why it is called as brightness scan, that we are going to discuss today. So what is the principle of B-scan? So during the procedure, the examiner sent the ultrasound inside the patient eye, and when the ultrasound traveled through the ocular structure, some amount of the ultrasound reflected back, and this is known as echo. The higher the dense structure, more stronger the echo is, and echoes in B scan are converted to dot with brightness intensity that is proportional to the echo amplitude. So in the uh, so the sound wave have different velocity in different medium, and it is seen that sound wave velocity, that is ultrasound velocity, is more in denser medium than in liquid medium. So in our eye, cornea is a denser medium, lens is a denser medium, but aqueous humor and vitreous humor are less denser medium. So when ultrasound travel through these structures, then in the border of those medium, the ultrasound, some amount of that sound wave is reflected back, and it is received by the receiver, and it is creating the echo, and it is converted into dot. So the more echo, that is more amplitude of the echo, the brighter dot will be there, and if the amplitude of the echo is less, then the brightness of the dot will be also less. And if we combine these all echoes, that means all dots together, then an entire eyeball picture or image can be seen in the display. So this is how B scan works. So in B scan, first of all, the electrical impulses are converted into ultrasound, and it is sent through the ocular structure, and that the reflected ultrasound is again converted to electrical impulses, and it is displayed on the screen. So this is how ultrasound works. So now you are seeing the A scan probe and B scan probe. Look how different they are. B scan probe is more bigger than the A scan probe. Now there is some terminology used in B scan. First of all, resolution, that means ability to distinguish between two echo, that is resolution. Amplification means processing of the echo before displaying on the screen. And gain is the amount of amplitude that we can change. That means in during the procedure, uh, if we want to see the vitreous opacity or vitreous detachment, then we need to increase the gain. So after increasing the gain, more frequency of the ultrasound will be, so that we can see the detailed structures also. But if we lower the gain, then we will not see vitreous, but we can see the retina and sclera, which have 100% reflectivity. So this is how gain works. So you are seeing at the B scan machine now, and that is the display, and you are seeing the B scan probe as well as the pedal. By switching it, we can send the ultrasound. So it is the B scan probe, and you are seeing a line over this probe. So this line indicate that the orientation of the sound beam. That means the sound beam is not uniform as the B scan probe surface. It sent to the eye in a orientation line wise. So that I will discuss later on. That so during the procedure in B scan, we use coupling jelly, and the test can be performed open eyes in or close eyes, but maximum time we use in we perform B scan in close eye, by applying coupling gel over the eye, and over that eye we just move the probe or instruct the patient to move his eyes. So what happens that if we do not use that coupling gel, then sound waves can be lost in the air also. But if we using the jelly in between the probe and the ocular surface, then there will be no way to reflection of those sound wave, and all those ultrasound will be sent to the ocular structure. So this is the purpose of using the jelly, and also to reduce the friction of the probe we can use coupling gel. So the frequency of what is the frequency that we use in B-scan ultrasound? So we can hear sound of frequency 20 to 20,000 hertz, but in ultrasound which is used in, that is ophthalmic ultrasound, which is used in B-scan, it is about 8 to 10 megahertz. In A scan we use 10 to 12, in B scan we use 8 to 10 megahertz, and in ultrasound biomicroscopy we use 20 to 50 megahertz. So remember one thing, that more the frequency, lesser is the wavelength, and more precise the image will be, but lesser will be the penetration. I am again saying that more the frequency, lesser is the wavelength, so that there will be less penetration, but image quality will be very good. But lesser is the frequency, so that longer is the wavelength, that means deeper penetration, but image will be not that much high quality image, but penetration will be deeper. So in ultrasound biomicroscopy, actually we are examining the anterior chamber as well as ciliary body also. So here we are using 20 to 50 megahertz for a very clear image, but in case to evaluate the retina, sclera, and also orbit, we can examine by B scan, we need deeper penetration. So we cannot use high frequency of ultrasound. So we are that the ideal frequency of B scan will be 8 to 10 megahertz. By using it we can examine the retina, sclera also by it. So this is why this specific 8 to 10 megahertz frequency is used in B scan. So B scan is a two-dimensional cross-sectional image scan. So the image that we are saying is a two-dimensional image. So method, there is two method, contact method, immersion method. So in contact method we cannot see the cornea, iris. We are seeing or we can examine the ocular structure which starting from lens posterior surface to the remaining portion. But after using the immersion, we can examine the cornea, ciliary body as well as posterior portion also. So probe positioning. So there is three type of probe positions are there: transverse, longitudinal, and axial. Transverse probe positioning, here we place the probe on the sclera. Longitudinal, here we place the probe on the limbus, and axial, here we place the probe on the cornea. So what is the indication of B scan? So at first, if the ocular medium is very opaque, that we cannot examine or see properly posterior portion, that is retina, then we refer the patient for B scan. Because here we are using ultrasound that have the penetrating property, so that we can examine the retina very well. So if there is vitreous hemorrhage, tumor, then to see the location of the tumor, we use B scan. Or in case of retinal detachment, what type of retinal detachment it is, to see that we use B scan. In case of choroid detachment, PVD, to see whether it is PVD or retinal detachment or choroidal detachment, we use B scan. Choroidal melanoma, also vitreous opacity and asteroid hyalosis. To see all these things, we use B scan. So this is transverse probe positioning, where the probe is placed on the sclera as you are seeing. So this is transverse method, and you can see that the line of the probe is in horizontal position. That means the sound wave will go through the horizontal meridian but not in the vertical meridian. So like this, the image formation will be, that means the display, in the display we can see this image, that means in this section. So transverse scan is like this, where the mark, that is line on the probe, will be horizontal and it is placed on the sclera. So this is longitudinal position, where the line on the probe should be 90 degree, that means perpendicular to the limbus. So this is longitudinal position. As you can see that the probe line is perpendicular to the limbus. So this like this we can see the posterior portion image in this orientation, as there is a line is drawn, so that it will be easy for you all to understand. And this is axial scan, where the probe is placed over the cornea. So this is a B scan procedure of normal eye. So before discussing two different ocular structure abnormalities, one thing I need to discuss with you all, that there is two type of examination techniques are there. One is kinetic and another is static. In kinetic, probe is movable and eye is stationary, or eye stationary and probe movable. Okay, that means probe movable, eye stationary, or probe stationary, eye movable. This is kinetic. And in case of static, probe and eye both are stationary. Remember, in kinetic method, whether probe is stationary and eye is movable, or eye is stationary and probe is movable. That means in kinetic method, the patient is looking to a fixed position and we are moving the probe to different direction. It can be superior, inferior, nasal, temporal. And again I say that to see the inferior portion of the inferior portion of the retina, we will place the probe superiorly, and to see the superior portion of the retina or the fundus, we need to place the probe inferiorly. To see the temporal portion, we need to place the probe nasally, and to see the nasal portion, we need to place the probe temporarily. So this is kinetic method, where we whether we can instruct the patient to move his eyes and probe will be stationary, that is static, stable position, or we can say the patient that to fix his eyes to a fixed position, we can move the probe. But in case of static, the probe and eye both are in stable position and the ultrasound is sent into the eye. Now this is a picture of normal eye which was taken by ultrasound, B scan method. Now you are seeing at the PVD, that is posterior vitreous detachment. Another thing I need to discuss with you all, that there is a difference between vitreous detachment and retinal detachment. Vitreous detachment, here the echo will be not that much high, that means amplitude of echo will be low, but in case of retinal detachment there will be higher amplitude echo present, but in case of vitreous detachment lower amplitude of echo is present. This is open funnel retinal detachment. So in retinal detachment, there is presence of funnel, we can see. I'm telling why. Because retina is joined to the eye in two position. One is at ora serrata, another is at optic disc. So when retinal detachment is seen, then or in optic disc and ora serrata, retina is joined there. But in between them, retina is in hanging position. So it is appear like a funnel shape. Now this is a closed funnel. That means it is a chronic retinal detachment. So there is a accumulation of cell in between that detached portion. So this is a choroidal detachment. So you can easily differentiate whether it is retinal detachment or choroidal detachment by seeing its orientation also. That in retinal detachment it can be a foldable or wavy appearance and funnel appearance will be there, but in case of choroidal detachment there will be kissing sign will be there. That means the wave will be attached to the uh, 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 posterior portion, but in case of RD the waves will be floating on the vitreous. That means the funnel is forming, but in case of choroid detachment there will be semicircle wise wave can be present. So this is dislocation of the lens. This is choroidal melanoma that you can see that this elevated portion is choroidal melanoma. This is giant retinal tear, as you can see here. This is a retinal tear. This is choroidal detachment. You can see there is a space in between them. So by seeing this you can easily understand it is a choroidal detachment, and this is also an open funnel retinal detachment. So here you can see the optic disc here, it is connected, and in the anterior part there is ora serrata is connected with retina. So this is choroidal detachment kissing choroid. So here you can see that kissing choroid in between these two. So by seeing these things you can easily diagnose whether it is retinal detachment or choroidal detachment. Or you can do another thing to identify whether it is PVD or RD or CD. That you can make the probe at stable position and instruct the patient to move his eyes up, down, nasal, temporal, and you observe the movement of that detached part to identify whether it is PVD or RD. So movement of the vitreous in case of posterior vitreous detachment, movement is very much floating movement is there, but in case of RD, as it is connected with optic disc and ora serrata, movement will be not that much. That is, the movement is moderate, but in case of choroidal detachment there will be no movement, but in case of RD there is moderate movement, and if it in case of PVD there will be maximum movement can be seen. So by seeing the movement also we can easily differentiate whether it is PVD or RD or CD. So it is also a PVD that you can see that there is a thin mm, layer is there, that is vitreous. So another thing that we can do, that in case of only in case of high gain we can see the vitreous detachment, but in case of low gain we cannot see vitreous detachment. So if you are confused in whether it is PVD or RD, just do low gain, and if in case of low gain there is still the detachment is seen, then it is surely retinal detachment. It cannot be PVD or vitreous detachment, as vitreous cannot be seen in low gain. So this is how we can make a differentiation also. So this is choroidal melanoma that you can see there is a collection, the melanoma formation is there. And so that's all friends. Thanks for watching, and please don't forget to like my video and subscribe to my channel. Thank you so much.